Another important yet and commonly encountered clinical scenario: high blood pressure in a young adult or in situation where a resident have to evaluate for secondary hypertension. Simple topic, but students are bit confused, residents. So the topic of discussion is related to that: causes of secondary hypertension. Same way, in a patient with a young age group coming with high blood pressure, how to evaluate, how to approach. In the book, the tabular column is big. They are directly jumping into ARR, that is aldosterone-renin ratio. So those are all the investigation perspective. But before that, you should be very clear about the common presentations, what are the etiology. That is the discussion. First, when we take a secondary hypertension, it can present as mild to moderate blood pressure or very high blood pressure. The age group, at what age group the patient is presenting, whether it is chronically present or suddenly it is deteriorating, what are all the associated symptoms the patient presents with, whether patient only present with isolated BP or the patient came for some other symptom and during evaluation it was found to be high. These are all some details you have to know. Causes. The most common cause, secondary cause of high blood pressure is renoparenchymal cause. The first one. What is this renoparenchymal cause? In the kidney has cortex and the medulla. Parenchyma is the cortex mostly and some part of medulla also. Whereas if we take a kidney in toto, any problem which is related to the kidney function, commonly glomerulonephritis. Glomerulonephritis is the inflammation of the glomeruli. If it persists for a long period, we can say it as chronic glomerulonephritis, which comes under CKD. Multiple cyst, that is ADP-CKD. Even in situation of acute kidney injury, any renal dysfunction causing high BP. A good example is IgA nephropathy. It is a glomerular involvement. Patient might present with isolated high BP. So the most common cause of secondary hypertension is renoparenchymal cause, under which whatever the condition we discussed, those comes. BP might not go extremely high unless the patient is in RPGN. That is why a patient presents in OPD with isolated rise in the blood pressure, probably you might be dealing with this one. Presence with mild to moderate rise in BP. Renoparenchymal cause. Coming to the second one. A UG student, if we ask an intern what is the cause of any hypertension, since they have studied that UG curriculum, they will always come up with renal artery stenosis. The second etiology is renovascular causes. Renal artery stenosis due to any cause, atherosclerosis, some autoimmune disease, any vasculitis, some renovascular cause. So second broad category is renovascular. In that, renal artery stenosis, the second most common. In this, patient presents with extreme high BP also. Sudden onset might be there. Take renovascular. In the examination, you might get Brugge and all. Two causes we have discussed. Third one, related to the endocrine organs. What are those? For simple remembrance, remember as thyroid, pituitary and the adrenal. Any hormone related dysfunction related to this. Most common cause of isolated presentation in the OPD with high blood pressure may be hypothyroidism. Hyperthyroidism also causes. Then comes to this hypo and hyper might not go to the extreme degree, might be on the moderate level of rise in BP. In the adrenal, cortex is there, medulla is there. Causes related to the cortex, related to the medulla. Cortex, cortisol is secreted, Cushing syndrome, Conn syndrome, medulla pheochromocytoma. Any malignancy which is producing more, just adrenal related. There only aldosterone and renin comes. Aldosterone goes high, aldosterone comes low. Any cause causing high aldosterone activation, it might be in the receptor. So this is related to the adrenal. But the problem is there is no need to jump and evaluate for adrenal aldosterone. This receptor problem is there or not directly, because always look for the common things. So rule out renoparenchymal, check for renal artery stenosis in the Doppler, then this endocrine causes you can evaluate. Aldosterone high, usual presence as moderate to high BP. This is related to adrenal cortex, whereas in the medulla, pheochromocytoma features sweating, palpitation, sometimes orthostatic hypotension, the associated findings will be there. And Cushing syndrome, cortisol being secreted extra from the adrenal, or patient might have taken steroid. So that can also cause high BP. So adrenal we have seen, thyroid we have seen, pituitary, very very rare. Growth hormone, high growth hormone, acromegaly. These are some theoretical description. You might not find a case of acromegaly presenting as hypertension for the first time in the OPD. Most likely 99.9% you might not encounter. Okay. In this adrenal overactivation, aldosterone renin, this system, there only those syndrome where aldosterone finally goes and act, that receptor overactivation. Aldosterone is not there, this receptor got overactivated, water got retained. Those are multiple syndromes are there. That might be for your entrance, but practically those are very very rare. Even if it presents, you will have associated finding. Potassium acid base status gives the clue. High aldosterone, potassium might be low, probably patient might be having alkalosis. So the approach, how to proceed further, we are not discussing. That is why I am not jumping into it here. Just remember pituitary, thyroid and adrenal. Most commonly you might encounter hypothyroid or hyperthyroid. Okay. So 3 we have seen. Renoparenchymal, renovascular, endocrine we have seen. Endocrine means 3 under adrenal, cortex and medulla. Coming to the fourth one, drugs. What are the drugs which can cause high BP? For theoretical discussion, 5 to 6 drugs are there. For the practical purpose, just remember NSAID can cause mild rise in BP. NSAID, non-steroidal anti-inflammatory drug. And other drugs like steroid, oral contraceptive pills, cyclosporin tacrolimus. But whenever a patient is taking cyclosporin tacrolimus, he might not come to you with isolated BP. So that itself already given the clue the patient is on some immunosuppression that is causing the, probably the disease per se is causing. So for drugs related, just remember steroid, OCP, NSAID can cause. And any other drugs probably you can forget also, at least for the clinical purpose, these drugs you remember. And the last one, the fifth one, only 5 causes will be there. Others may, what are all the things which are common? Obesity, obstructive sleep apnea syndrome, autoimmune diseases, any vasculitis, any autoimmune disease. Obesity, obstructive sleep apnea, autoimmune disease and coarctation of aorta, which are very very rare compared to all this I am saying. And don't comment, sir, coarctation of aorta I have seen 2 cases. Yes, if you are in cardio posting or if you are in college where the high, if it is the referral center, you might see 1 or 2 cases, but compared to all this, COA, coarctation of aorta, is rare. So under others, the 5th category, just remember obesity, obstructive sleep apnea syndrome, any vasculitis, that comes under autoimmune disease only. And the final one is coarctation of aorta. That's all. This is how the approach have to be. I hope you are remembering the 5. Renovascular, renoparenchymal, endocrine, thyroid, adrenal and pituitary. Then drugs, then the others. In the others, autoimmune, OSAS, obesity. You always get the clue from the history only. If a patient is obese, before asking the history only, you might have found what could be the contributing factor for obesity. So with this, which is the most common, as I told, renoparenchymal, always look for urinary albumin. So you will try to find that. Then you can get a Doppler, renal artery Doppler, then thyroid. So these might be your first tier investigation. And of course, always check for HbA1c. It might be diabetes and superadded comorbidity. This might be there. Then subsequently you can go to further step if other things are ruled out. If you are suspecting adrenal because of the other parameters, potassium, metabolic acid state, acid or base state, then you can plan further. 24-hour unit, these adrenal medulla hormone levels are there in the urine, in the blood, aldosterone renin ratio is there, that you can proceed well and good. But to proceed, you should be very clear about the causes. So that's all. The causes, this question definitely you are going to encounter in your final exam. If the examiner asks, this question should be a easy go for you. Just tell one by one, part of it. Parenchymal, vascular, endocrine, drugs, others. That's all, sir. Apart from this 99.9%, only these are all the things. Otherwise, patient might be a case of primary hypertension. Always there are conditions present with mild to moderate, some condition where BP goes very, very high. Most likely pheochromocytoma, arterial stenosis, CKD. Okay, these are the situation. BP goes very high when the patient is in volume overload. I hope the residents, suppose if you come across this video, make sure you are thinking in terms of this line whenever you are seeing a hypertension for the first time in young patient or whenever you want to evaluate for secondary hypertension. Bye bye. Summary, no need I hope to tell because we discussed it multiple times. Only 5. Remember this like that for the clinical purpose. Bye bye. We will see in the video.